It's my pleasure to introduce Dr. Caridad Ponce Martinez. She is the Director of Clinical Services in Addiction Psychiatry and an addiction psychiatrist at the Addiction and Comorbidity Treatment Service within the Outpatient Psychiatry Department. And Dr. Ponce Martinez will introduce today's speaker.
Thank you, Tony. So Dr. Sarah Wakeman, we're so excited to have you here. Dr. Wakeman is a Senior Medical Director for Substance Use Disorder at Mass General Brigham in the Office of the Chief Medical Officer. She's Medical Director for Mass General's Substance Use Disorder Initiative, Program Director for the Mass General Addiction Medicine Fellowship, and an Associate Professor of Medicine at Harvard Medical School. She received her AB from Brown University and medical degree from Brown Medical School. Completed residency training in internal medicine and served as chief medical resident at MGH. She's a diplomat and fellow of the American Board of Addiction Medicine and board certified in addiction medicine by the American Board of Preventive Medicine. She served on Governor Baker's Opioid Addiction Working Group, and nationally she serves on ASAM's, American Society of Addiction Medicine's Ethics Committee. Clinically, Dr. Wakeman provides specialty addiction and general medical care in the inpatient and outpatient setting at MGH and also Mass General Charlestown Health Center. Her research interests include evaluating models for integrated substance use disorder treatment in general medical settings, low threshold treatment models, recovery coaching, physician attitudes and practice related to substance use disorder, and screening for substance use in primary care. Welcome and for your presentation.
Thank you so much, Dr. Ponce Martinez. Thanks for having me. Really excited to join you guys. So I am going to talk today about integrating substance use disorder care into the medical system. And please feel free to enter questions into the chat, or if you want to stop me and ask questions, I'm open to that as well. My disclosures: I'm an author for Up to Date and a textbook editor for Springer. I think you all are well aware that we're in the midst of a public health crisis. The number of overdose deaths now top more than 100,000 per year, which is the peak for overdose deaths across our country, and really now has surpassed the peak number of deaths for motor vehicle accidents and for HIV deaths at the height of the HIV crisis. And I think one of the many tragedies of the overdose crisis is the fact that many of these deaths are due to a treatable health condition. If we think about opioid use disorder, it's one of the most treatable things I treat in general practice or addiction medicine. And we have tools both to treat people who have addiction, but also to keep people alive who are using drugs, and public health strategies to reduce the risk of overdose. And so I think fundamentally, this sort of ongoing public health crisis is really a crisis due to inadequate care and a long history of failed drug policy in our country. When we think about what's driving the current death toll, it's really the unpredictable supply that's out there in terms of the illicit drug supply. So there's obviously been a lot of focus on the onset of the current crisis back in the 1990s, where there were high rates of death due to prescription opioids. And we've all seen, news headlines and movies and now Netflix shows about the prescription opioid crisis that started in the late 1990s. I think the thing that's interesting as we think about how to address the crisis is really thinking about the multiple waves of the overdose crisis. And the CDC talks about the first, second, and third wave. Some people have coined the current term the fourth wave. But what that really means is the first wave was driven by prescription opioids, but we saw both prescribing rates and death due to prescription opioids really peak around 2012 and begin to decline thereafter. And rather than sort of heralding success in the overdose crisis, what we saw was actually the onset of a more rapid and more fatal crisis. That as prescription opioid access decreased without a concomitant increase in access to treatment and harm reduction, rather than stopping using opioids, what happened was people shifted into the illicit drug market. In 2013, that was really rising rates of heroin-involved overdose deaths. And then you see this dramatic overtake in 2015 and onwards of illicitly manufactured fentanyl. And right now, although we are in a much more polysubstance use-focused crisis with rising rates of cocaine and psychostimulant-involved overdose deaths as well, the thing that's driving the death toll continues to be illicitly manufactured fentanyl. And I think that really gets to, when we think about how to address crises, the opportunity we all have as clinicians and physicians and healthcare providers in addressing the demand side of the crisis, that our country's drug policy is often focused on supply-focused interventions. And we see in this current crisis, the shifting, sort of squeezing the balloon effect, that without addressing demand, rather than people getting well, we see actually a more rapid death toll. Unfortunately, things only got worse since the onset of the pandemic. The year before the pandemic, we actually, for the first time, had seen a slight downturn in overdose deaths, and we're beginning to see perhaps the result of promising changes and increased access to treatment and other interventions. And yet then COVID happened. And of course, the world shut down, and many of the factors that drive chaotic substance use and the risk of overdose, so things like trauma, boredom, loss of economic opportunity, loss of hope, stress, being alone, isolation, not being able to access needed treatment and harm reduction services, all went into effect. And we saw a pretty rapid beginning of an uptick in overdose deaths, both fatal overdoses and ED visits for overdose events and other overdose-related activity. And I think when we think about COVID, it's interesting to compare sort of our societal and public health response to the COVID pandemic and then to the overdose crisis, where we really saw this amazing all-hands-on-deck response to the pandemic. And of course, it was terrible and traumatizing, and I hope we never have to live through something like that again. And also, there were moments that were really inspiring, that rapidly barriers that had seemed utterly insurmountable, whether it was switching to telehealth or delivering medical care in non-traditional settings or training up people who'd never done a certain type of medical care to deliver it rapidly. We saw all of that happen. We saw operating rooms and field hospitals switched into ICUs for people who needed them. I was redeployed to a COVID surge team, and I had a urogynecologist many decades into practice and a reproductive endocrinologist and a gyn-onc doctor who really hadn't done inpatient general medical or infectious disease care since residency, who quickly learned protocols and learned how to take care of a brand new disease. And I think that sort of all hands on deck, sort of putting our minds together to address what have seemed like insurmountable barriers is what we would hope to see when there's a fatal public health crisis. And I think as an optimist, I hope that we can take some of that energy and really think about how do we fundamentally address the overdose crisis and tackle these barriers that have long stood in the way of delivering good care. When we think about overdose, we sometimes hear the sort of catchphrase of addiction doesn't discriminate. I think that's debatable, but definitely anyone can be at risk of substance use disorder. But overdose, who dies from fatal overdose, definitely does discriminate. So those who are at greatest risk of death are often those who are already the most marginalized. And we see that in data across Massachusetts. When we look at what was initially called the Chapter 55 data set or the public health data set, people who are at greatest risk of dying from overdose in Massachusetts are people who've experienced homelessness, people who've been imprisoned in our carceral system, postpartum people, and people with serious mental illness. So people who are already marginalized, who are already dealing with very complex competing health and social determinants of health complications. And yet when we think about the traditional addiction treatment system, it really hasn't necessarily been designed with those populations in mind. It's often been a high threshold, somewhat complicated to access treatment model. And so you have this mismatch of people at the greatest risk of death are going to be the least able to access addiction treatment that's out there. And so the death rate continues to get worse in those communities. Unfortunately, we've seen the health harms of racism, of course, across our society, but particularly when we think about the overdose crisis. This is true nationally, where the greatest rate of increase in overdose death is amongst Black individuals and American Indian and Alaska Native individuals. And it's absolutely true here in Massachusetts. So this is the most recent data from Massachusetts. They put out, the state puts out statistics every 6 months. So this is the June 2023 data. And you can see here that overdose death rates amongst white non-Hispanic individuals actually decreased, which is great news. And yet we see this increase amongst Black non-Hispanic individuals, Hispanic individuals, and by far the highest rate is amongst American Indian individuals across Massachusetts. And so these racial and ethnic disparities in overdose death continue to worsen, and they worsen here in our own backyard in Massachusetts. And that's really not surprising. Of course, we know racism impacts all health outcomes, and the structural barriers in our society and our healthcare system are tremendous. But when we think about our country's approach to drug policy, it has always been infused by racism. And so if you look back to the time periods when some of our key drug laws were being passed, like the Harrison Narcotics Act in 1914, which was actually a tax law that was the first law that made it illegal for doctors to treat drug addiction with a drug, and then laid the groundwork for the hurdles around using medication treatment for opioid use disorder. There are headlines like this one in the New York Times really playing on anti-Black racism to help garner support to pass those laws. Similarly, some of the anti-cannabis laws really played on anti-Mexican and other racial and xenophobic fears across our society. And so we've seen that play out in our drug laws when we think about the so-called war on drugs, and then what happens to people in the criminal legal system, where Black, Latinx, and American Indian individuals experience discrimination at every stage of the criminal legal system. They're more likely to be stopped, searched, arrested, convicted, and harshly sentenced for drug law violations, despite the fact that white and Black individuals, for example, use drugs at the same rates, and yet the criminal impact is so differential in terms of outcomes. And this has led to the majority of people in federal and state prison for drug offenses being Black or Latina across the country. And so I think the war on drugs is an interesting thing to think about when we think about where we got here. And honestly, this visual graphic could be the overdose surge, but it actually is a number of people who are imprisoned in our state and federal prison populations. The U.S. far outpaces any other country in terms of our rate of incarceration across our population, but it hasn't always been this way. So this sort of mass incarceration experiment was something relatively new that really began in the 1970s and 1980s with the so-called war on drugs. You can sort of track out the timeline where Nixon declares drugs to be public enemy number one. The DEA is established. We see the Reagan Just Say No era, the anti-quote-unquote drug abuse act that led to the sort of racial differentials in sentencing for rock versus powder cocaine, and then on and on. And you see this rising rate of people who are imprisoned predominantly for drug-related offenses or acquisitive crime related to substance use disorder. And so this has led to incredibly high rates of people who are imprisoned who have substance use disorder, and people who've been involved in substance use in terms of the reason that they got sent to jail or prison in the first place. And when we think about some of these racial inequities, whether it's in mass incarceration or in the overdose crisis, I think it's important to step back and realize that the system is really functioning as designed, that the war on drugs was not an accident. The racial disparities were not an accident in terms of who got imprisoned. And when we're thinking about the harms of racism and the overdose crisis today, that's also not an accident. And this was actually a quote from the former Nixon domestic policy chief, who really said on record, that the war on drugs was at its core really about racism and about, as you can see here, I won't read the quote. We think a lot about the criminal legal system when we think about sort of the health harms of drug policy, but there's also other systems of so-called support that can perpetuate the war on drugs and some of the racial disparities we see in outcomes. And when we think about the foster system, that is another area where women and birthing people of color, particularly Black, Latina, and American Indian parents are far overrepresented in terms of custody loss and surveillance by the foster system. You can see here that 1 in 17 white children have been removed from their parents' care, and yet 1 in 9 Black children and 1 in 7 American Indian children. And far and away, the most common reason for family separation are allegations of parental substance use. When we think about sort of the impact of family surveillance in the child welfare system, again, substance use is the main reason for involvement. And we know that Black communities already experience intense social surveillance. And despite, again, similar rates of use, Black communities are much more likely to be reported to child welfare authorities. And that has tremendously negative impacts, not just on the child, but also the parent. So although sometimes you'll hear people say, well, losing custody would be a motivating factor for a person. But in fact, losing official custody increases drug use for the birthing or parenting person by a factor of 4. And there's beautiful and painful qualitative work showing the significant psychological toll, really getting at the identity of human beings and leaving them with these emotions of guilt, bitterness, anger, feelings of failure as a parent, and helplessness. And so that's sort of the context. And I think it's impossible to be in the field of addiction medicine without thinking about policy. And it's one of the things that makes it such an exciting area to practice, because there's so much that needs working on, but also really interesting opportunity to think about how we can do things differently. And it's not just racism when we think about the sort of the bad drug policy and clinical protocols out there that exist, but also general stereotypes of drug use, particularly stigmatized drug use, that have long impacted practice and policy. The individuals at the top of this screen, I'm not sure if people will know them, but it's Dr. Dole, Dr. Niswander, and Dr. Creek. They were the 3 physician scientists in New York who discovered methadone as a treatment for opioid use disorder. So Dr. Dole was actually an endocrinologist by training who came to understand severe opioid use disorder as being very similar to other endocrine conditions like adrenal insufficiency or hypothyroidism or insulin-dependent diabetes, where some people need a chemically similar molecule medication to maintain normal homeostasis. Marie Niswander was a psychiatrist who ultimately they married, and they ran a lab at Rockefeller where they did these amazing early experiments and discovered and published the first papers in JAMA in 1965 of methadone as a really life-saving treatment for opioid use disorder. And Mary Jean Creek, Dr. Creek, was initially their research assistant who took over the lab and went on to run the lab successfully for many decades. As Dr. Dole says here, he was interviewed about his career, and he sort of reflected back on stumbling into the field of addiction and talked about needing to unlearn some of the stereotypes that he'd been exposed to as a member of our society, where stereotypes about drug use abound, and that he really had to unlearn this traditional image of people with addiction as being weak or hedonistic or unreliable or deprived or dangerous, and that that's entirely false. And yet that myth has continued to be believed by much of the medical profession and much of the general public. And we've seen that distort public policy and clinical care models over the past many decades. So what is effective treatment? Well, the great thing about science is that it is true whether people believe in it or not. And thankfully, we have decades of research, dating back certainly to 1965 to Dole and Swander's experiments, but even before, about what are effective interventions to treat substance use disorder. And substance use disorder is a treatable good prognosis health condition where we have a range of treatments similar to other chronic conditions. For opioid use disorder in particular, medication is a cornerstone of treatment. Medications, of course, exist for opioid, alcohol, and tobacco use disorder, as well as off-label medications that are used for other types of substance use disorder, like stimulant use disorder. We have psychosocial interventions like cognitive behavioral therapy, motivational enhancement therapy, contingency management that have been shown to be effective. We have non-formal treatments, so recovery supports are not formally treatment, but can be incredibly valuable for people as they're engaging in care and navigating the recovery process. And that can be mutual help organizations in the community like Smart Recovery or 12-step groups, but it can also be recovery coaches, recovery community centers or learning centers, and many other types of recovery supports. And then harm reduction, which to me is a part of treatment. So much like many of the things when I'm in my general medical practice that we do in chronic care management is actually harm reduction. It's reducing the negative consequences of a health condition. It's not in conflict with treatment. It's really a part of that continuum. And the same is true for substance use disorder management. When we think about opioid use disorder, especially, and this is particularly relevant, of course, given the ongoing predominantly opioid-related overdose death crisis that's going on, we know that access to medication treatment is life-saving. We've seen this at the population level. We've seen this in randomized clinical trials and comparative effectiveness studies. This was a study in the country of France, where folks who are familiar with the history will know that France, in the midst of their own heroin crisis back in the 1990s, expanded access to buprenorphine and allowed any physician to prescribe it. So there are no training requirements, no patient limits, no toxicology or counseling requirements. They were able to get 90,000 patients treated in relatively short order. And they saw dramatic results. They saw a 5-fold reduction in heroin overdose deaths, a 6-fold reduction in active injection drug use, and a decrease in HIV prevalence amongst people who inject drugs. At the meta-analysis level, there are many systematic reviews looking at the impact of medication treatment for opioid use disorder on mortality. Both methadone and buprenorphine have been shown to reduce not only overdose-specific mortality, but all-cause mortality. There are really very few medicines we can offer in clinical practice that have this type of mortality impact. This is on the order of aspirin for a myocardial infarction. And so to think that we can really offer this life-saving treatment for people who are dealing with a potentially fatal health condition is incredibly important. And yet it's important for both us as clinicians to understand, but also to be able to share with patients, what does the evidence show? So although patients should absolutely choose whatever treatment, intervention, and modality and pathway is right for them, they need to be informed of the risks and benefits and the likelihood of different outcomes of different treatment pathways, much like we would for any health condition, where we would talk through what does the evidence show and really inform people to make decisions that are based on their own preferences, but informed by data. And I think sometimes that doesn't always happen, in part because our colleagues, especially folks who don't ever work in the addiction space, may not understand sort of what is the research around addiction treatment, particularly medications for opioid use disorder. I'm work a lot in the general medical setting, and I think many people still think of sort of inpatient treatment or quote unquote rehab or detox as being sort of the best treatment option for any type of substance use disorder. But for opioid use disorder, there's really never been a study to show that that's effective. And in fact, there's quite a lot of evidence to suggest that we should be worried about people who are going to non-medication-based withdrawal management programs for opioid use disorder. This was an early small clinical trial in The Lancet looking at individuals who are in an inpatient setting with heroin use disorder and randomizing them to buprenorphine therapy for a year with psychosocial counseling versus withdrawal management with buprenorphine and then a year of intensive psychosocial counseling, and showed really just this dramatic Kaplan-Meier survival curve. We don't really see these types of results usually in clinical trials, where in the group that got buprenorphine, 75% were still in treatment and 75% had negative toxicology, whereas the group that had withdrawal management and psychosocial counseling, no one stayed engaged in treatment. Actually, 20% were dead by the end of the 1-year study. So really dramatic. And I think we don't have other interventions where we have a lack of not only clinical benefit, but also mortality concern, where it continues to be recommended and paid for as a treatment modality. When we think about sort of the comparative effectiveness of different treatment pathways, colleagues and I did this study using a national claims data set where we compared no treatment to 5 different treatment pathways. So looking at inpatient treatment, either withdrawal management and or residential treatment, intensive outpatient programs, regular non-intensive outpatient behavioral therapy, medication treatment with buprenorphine or methadone, or antagonist therapy, so medication treatment with naltrexone. And we saw that the only treatment that was associated with reducing overdose, both at 90 and 180 days, was methadone buprenorphine. So you can see the kind of light brown line is methadone buprenorphine treatment, and then the orange and black line that cross over is actually inpatient treatment and no treatment, which ended up being exactly similar in terms of outcome. The other sort of evolution over the past decade that's been really exciting to see is this concept of utilizing touch points of the healthcare system as reachable moments. Beginning really in sort of the 2010, early 2010s, there were a number of studies looking at this idea of what would happen if we take sort of all comers to general medical settings and make it really easy for them to access addiction treatment. So rather than the older model of referring people out, where often there's long waiting lists, it was quite complicated to engage in care, there are many barriers, to really try to utilize this as a reachable moment, a touch point where we can initiate treatment and connect people directly to care. So in 2010, there was an uncontrolled study at Boston Medical Center where they took all comers to the general hospital and they offered them to start methadone in the hospital, which at that time in 2010 was not happening. And they found that if they did that, these are people not coming in asking for treatment, but if they were offered methadone, actually 82% would present for follow-up care for ongoing addiction treatment, which is pretty remarkable. Another group at BMC then did a randomized controlled trial looking at people, again, all comers in the medical service, randomize them to either medically managed withdrawal and then a referral to buprenorphine treatment in the community, versus initiating buprenorphine and directly connecting people into care in the community. And they found a dramatic difference that those who were started on buprenorphine during the hospitalization and seamlessly connected into care, 72% of them would continue on in care, versus those who had medically managed withdrawal in the hospital and then were given a referral of buprenorphine, only 12% entered treatment after that. And I think that was really, sort of practice shifting, especially at that time where honestly, many people weren't even getting withdrawal management or referral to buprenorphine, let alone having treatment initiated in the hospital. And so began this sort of body of research really began to pave the way for this idea of what would it look like if we brought addiction back into the medical system. A group at Yale led by Dr. D'Onofrio and her colleagues took this a step further and said, okay, not just hospitalization, what if we use the ED as a touch point where we could actually initiate treatment and connect people into care? They did a 3-arm multi-site intervention where they took, again, all comers, 10% of people who came into this study actually were brought in after overdose against their will. So this is a population that was not coming in necessarily asking for help. And they did a 3-armed RCT where one arm got a referral to outpatient treatment, one arm got a brief intervention referral, and then one arm got initiated on buprenorphine in the ED and then referred. And just that short initiation, it was like a 3-day bridge prescription of buprenorphine, was enough to make a remarkable difference. So those who got buprenorphine from the ED, a month later, 78% of them were still engaged in care versus 37% of those who got a referral and then had to wait a day or two to get into buprenorphine treatment. And not surprisingly, buprenorphine treatment is associated with fewer days of opioid use. There's also been a whole body of evidence around treatment in primary care settings, that patients who are getting their primary care and have a trusting relationship with their doctor can get their addiction care right there. And that access to specialty care, of course, is important, as well as counseling like cognitive behavioral therapy. And yet primary care management is really quite good. This was a Yale study that looked at primary care management only versus primary care plus CBT and found no difference in terms of opioid use study completion or cocaine use between the two groups. And so this is just a smattering of some of the evidence, but there was a great and impactful report put out by the National Academy of Science, Engineering, and Medicine a few years ago called Medications for Opioid Use Disorder Save Lives. And I think the sixth conclusion is sort of says it all, that medication treatment is effective across all settings that it's been studied in, and that withholding or failing to have available all classes of FDA-approved medication in any care, criminal, legal setting is denying appropriate medical treatment. So that's sort of a full stop statement. If we're not making this available in every single care setting, bringing it into the medical system, we're really denying appropriate medical treatment. Unfortunately, much like we've seen racism impact our drug policy and bias impact our sort of clinical models and policy decisions, we also see that happen at the treatment level. And so there have been longstanding disparities in terms of buprenorphine access in particular. This was a claim study looking at national data, visits for opioid use disorder, and access to buprenorphine. So looking between 2012 and 2015 at patients who had an outpatient visit for opioid use disorder, and found that white patients were far more likely to receive buprenorphine treatment compared to Black patients or patients of other races. And you see the adjusted odds ratio there of 0.23 for Black individuals in terms of access to buprenorphine. Other scholars have looked at this from a sort of county level, so looking at the impact of residential segregation, racism in terms of access to medications for opioid use disorder, and found that individuals residing in counties with a low poverty rate and a low percentage of either Black or Latinx residents were significantly more likely to receive medications for opioid use disorder. So this notion of sort of buprenorphine has long been historically marketed to white and commercially assured individuals, and has laid the groundwork for these racial and ethnic disparities in access to buprenorphine treatment for opioid use disorder that persist even now. So when we think about sort of the shift from the science around what treatment interventions, impact of medication, utilizing hospitalization as a touch point where we can initiate treatment, it's also important to then think about, as we're thinking about bringing addiction treatment into the medical system, what types of models work, and how do we think about what people need who are not necessarily seeking out specialty care, but are really coming in often for a medical reason. And this idea of sort of what does low threshold care look like, and why might that be important for this patient population? And I think in addition to initiating care, our goal is always to keep people in care. If we think of substance use disorders, for many people, a chronic condition that requires care over time, treatment retention is something that we all are working towards. And we're seeing this now even in some contract and quality measures, which is an important shift in the substance use disorder space. And we know that treatment retention has benefit irrespective of what toxicology shows. And so I think there's been this important evolution away from the binary of sort of what does the urine drug test show to a broader perspective of how is this human being doing? How is their life going? How are their relationships going? How is their functional status? And this was an interesting study where they looked at treatment retention and the impact of treatment retention on quality of life. That treatment retention was strongly associated with quality of life, irrespective of what the toxicology results showed. So toxicology results really were not associated with the quality of life, but patient self-reported substance use was. And so I think shifting away from this binary of use versus no use, which is really all a toxicology test can tell us, to self-report where someone may be reducing their use over time as a part of the engagement process, and that leads to improvements in quality of life, irrespective of whether that sort of binary abstinence line has been crossed. And so to do that, to really shift into a framework of retention and engagement and quality of life, we have to think about the structure and delivery of care and how that impacts people engaging in and staying engaged in care over time. And this is a qualitative study of a multi-site clinical trial of methadone buprenorphine treatment for opioid use disorder. And they did a follow-up where they interviewed patients who either were able to stay connected in care versus those who fell out, and looked at some of the themes about patients who disengaged versus patients who engaged and were retained in care. And they found that, patients fell out of care when they weren't welcomed back, when the system was not welcoming and opening its arms to them. And so one quote was, you could only miss 14 days in a row to stay on it. So I came back on like the 15th day and they told me I was no longer eligible. And really not a model we want to think about when we're thinking about a potentially fatal public health crisis, that we want to be opening our arms and welcoming people whenever they show up into care, and making it as easy as possible for them to reconnect and stay connected. In contrast, patients who were able to stay engaged really reported the impact of caring staff, that staff who worked with them, who were nice and caring and respectful, who offered support and encouragement, were some of the most important factors. And one quote was, they showed me that there's light at the end of the tunnel. There's hope. You hear that? There's hope. And I was thinking of that quote yesterday. I was on a panel with the Deputy Director of Recovery Services for SAMHSA, who's a person who identifies as being in long-term recovery, who really talked about one of the most important parts of the work he's done over his career is training people about this idea that people get well when they feel cared for and when they feel like they have something to hope for, and that sort of holding hope for people and with people is one of the most important things we can do. And so that gets to the sort of the structural pieces then of if we're going to try to get to this place of really welcoming people in with open arms, making it as easy as possible for people to access addiction treatment across any point of the care continuum, whether that's specialty care or general medical care in the ED, the hospital, primary care, the OB office, the community, to really think about what is the difference between high threshold care and low threshold care. And people have tried to define this in their research that, low threshold care is care that aims to reduce any barriers to accessing treatment, that tries to have less stringent eligibility criteria to widen the door as much as possible, to broaden the reach of addiction treatment and reach communities that have not traditionally been able to access care. And part of this is a recognition that people who use substances face numerous barriers to engage in services. The first is the registration threshold. Just accessing care and staff can be hard. I'm sure many of you have tried to find care for your patients or for family members, and it's remarkably complicated. Even as a physician who works in this space, it is not an easy or sort of person-facing system to try to navigate. The next is the competence threshold. How do you actually communicate what you need, not what the care team thinks you need, but actually what your goals are and what you're working on. And that takes trust. And that's a tall order when our system has largely been designed in a way that punishes people for substance use. That why would someone feel like they can come into a new system of care and actually trust the care team that they're working with and share honestly what's going on with them? And that can take time. And so one of the, I think, beautiful thresholds is this concept of the efficiency threshold, that with a high threshold system, you sort of assume everyone's going to be able to efficiently get through each step. And yet some of our most vulnerable patients who are at highest risk of overdose are not going to be able to cross that threshold. And one clinician in this study said, what about that person who needs 1,000 cups of coffee with someone before they're ready to start speaking about their needs? A high threshold system is always going to leave that person behind. And so at the core of all of this is really a reframe in how we think about substance use, how we think about people who use substance use, and how we think about effective care models. And the mere existence of science has not been enough to change practice. And I think at its core, this is really a question of how do we change the fundamental ideology around addiction and substance use in our society. If folks are familiar with Dr. Walter Ling, he's an addiction psychiatrist at UCLA, and this is one of my favorite papers, maybe of all time. It's a sort of a meandering reflection on the history of medications for opioid use disorder in the U.S., and it's just a fantastic paper and worth a read. But this quote really is about this, concept that he ends up coming to, that really the mere existence of buprenorphine has not been as dramatic as one might hope, because the core ideology around addiction in our society it remains sort of very different from a treatable health condition model. That although it's very popular now to say that this is an illness, there's still this general societal notion that people should get off drugs and haul themselves up on their bootstraps and stay off no matter what. And that we as physicians have also been indoctrinated with that notion that people with addiction have brought upon themselves the suffering they deserve. And so even though now we're talking about this as a disease or an illness, our policies and frankly, many of our clinical models continue to reflect this attitude that yes, maybe people are sick, maybe they need help, but they also have done something bad, and therefore we shouldn't help them too much. And so as we think about beginning to shift, I think there's actually a lot to learn from sort of the philosophy of harm reduction, this idea of really centering people's autonomy and dignity and human rights in the care that we provide. The Harm Reduction Coalition has a number of really beautiful posters that you can hang up in your waiting room. This is one that we treat all our patients with respect, and the subtext underneath it is that we recognize our patients who use alcohol, tobacco, and other drugs value their health and have the right to the highest quality of health care. And I think that notion is just an important sort of kernel to always keep at the core. When I think about how we can bring this to the medical system that maybe hasn't always been a place where people have been able to get their needs met with substance use disorder, one thing I often challenge myself with is to think about the discrepancies between how we approach substance use disorder versus another health condition. So if we substituted in diabetes, would we treat the person this way? Would our care models look this way? Would we use the same language that we're using? And often the answer is no. And when there are those discrepancies, it's a great opportunity to think about where are there clinical or structural or ideological barriers that we can begin to address. I think as clinicians, we often focus and have been trained to think about the harm of the individual substance, when really a lot of the harm that people experience are because of bad policy, whether that's hospital policy that has created spaces that makes it hard for people to stay and get their health care, or societal policy that really punishes people who use substances and makes it hard for them to stay safe and stay well. So if you take a condition like endocarditis or an infection of the heart valves that is a potentially fatal and high-cost health condition, we often associate that with drug use, which of course is true, but really the thing that gives people infections is using in unsterile and unsafe manners, that people who have to rush use because they're afraid of arrest, they're using outside, they're unhoused, they don't have access to sterile injection equipment. Those are the factors that lead to infections. And so there are ways in which policy that criminalizes and punishes people can actually increase their risk, in addition to, of course, the risk that's inherent in the substance use disorder itself. We see, I think, a lot of barriers and challenges, both in our medical settings and in the community. So, in our healthcare settings, and I spend a lot of time in the hospital, although I think we often are not aware of it or don't think of it, our hospitals can feel really carceral in both their policy and their models. Many of the patients I care for have experiences of incarceration, and the idea of being confined to a room, having your sort of basic freedoms feel like they're being monitored or limited, being told you can't leave the floor, you can't go down and get a coffee, having visitor restrictions, or having your room searched, all of these things that can happen in healthcare settings can feel like a real reminder of being in a criminal legal setting. Our healthcare systems have often been focused on an abstinence-oriented idea of really trying to eliminate any drug use in people who are getting their healthcare in the hospital, rather than thinking about how do we really embrace the harm reduction philosophy and reduce the risks of people and try to engage with them and help them stay in the hospital. And I think that frame shift is a big one from where we've often started in a very well-intentioned way, but often sometimes harmful way around an abstinence-oriented environment. Again, our approach for substance use disorder is very different than for other health conditions. And even with education and training and anti-stigma work, there's an ongoing need for change maintenance, that we always have new trainees and new staff. And so you can do a big push about education, but that has to be maintained and ongoing, both at sort of higher levels and at the individual micro level. And then even when we create tremendous change in our medical settings, there's a lot of barriers in the community. There's discrimination in many care settings. There's a lack of the type of care patients need. Patients are complicated. They often have quad morbidity. Think of some of our patients who have multiple types of substance use disorder, severe mental illness, traumatic brain injury, unstable housing. And there really aren't community-based care models that truly fundamentally can address all of those needs. And that's a huge gap. And then regulatory barriers. So thinking about methadone, for example, which is a life-saving treatment and also incredibly onerous and hard for people to access. And that's because of decisions our society's made around regulation and access. So what can be the role of healthcare providers, both in systems change and also change in colleagues and addressing some of the barriers that we face? I think we all have this amazing opportunity to be a role model for compassion and anti-stigma, to just demonstrate what this looks like in our practice for colleagues to see. We can work to drop barriers to care, and that can be in your individual practice, or if you're in a leadership role at a systems level, incorporating harm reduction into the work you do and the policies and procedures, identifying when there are harmful policies that are leading to negative outcomes or threatening equity, how to really think about what opportunities we have to revise those. I think as teaching institutions, we can inspire trainees. Many of our trainees see the overdose crisis as sort of the social justice issue of our time and a real opportunity to get people involved in this, and of course, to broaden and deepen the addiction workforce. And then to be an upstander when we see bad things happening, when we see stigma or discrimination, to be able to sort of say in that moment that someone is being harmed. And I love this visual image of sort of the comparison of stigma versus liberation. This idea of, stigma keeps people and systems barren. That really comes from this negative place of assuming people are going to do poorly, assuming that they're lying or they don't have willpower, they can't help themselves, that they're not trustworthy. In contrast, really coming from a strengths-oriented perspective, this leafy tree of liberation, that you're partnering with patients, you're understanding their whole story and needs, you're sharing information, you're coming from a place of believing in them, that they can do something, they're telling the truth, they care about themselves and the community. And really that perception then infusing the human being to feel capable and trustworthy and caring. So at its core, all of this is really just talking about treating addiction like any other medical condition. We want to identify people who have this health condition. We want to discuss the diagnosis and available treatments. We want to treat without delay. And then some people need to refer for specialized care and for services. And that's what we do for any health condition. So if that's true, then why aren't all providers doing this? And there's been many survey studies that have tried to tease this apart, and they often say the same thing, that care providers will say, I don't have enough time, I don't have enough resources, these patients are complicated. And of course, all of those things are true. And yet that exists for every condition. Like, what do we do if we're not experts in multimorbidity? I can't think of anyone who's not dealing with multimorbidity, a lack of time, a lack of resource in their work. And it doesn't mean that it's not hard, but we don't opt out of treating other health conditions. And I think one thing that is missing is that a lot of the focus is on how hard or how dismal the overdose crisis is. And we don't talk enough about the joy and satisfaction of this work. As a general internist who also is an addiction specialist, I do general primary care and hospital-based medical work too. And there is nothing that is more satisfying or more joyful to be a part of treating than substance use disorder. It is by far and away the most rewarding thing I do in clinical practice. And I think sharing that joy with people is really important, especially if they don't have any sense of what this work really looks like. So I want to end with telling you guys a little bit about our what we initially called our substance use disorder initiative here at MGH as one example of how we've tried to begin to bring addiction treatment back into the hospital setting. So we started back in 2013 with our planning, and then launched our first clinical services in 2014. And from the beginning, we've tried to make this really a team-based effort. It takes a village to do this work, and I think we have always felt that multiple perspectives, multiple disciplines and departments allows us to learn and be better, but also provides better care to our patients. And so the many people on this is just showing you each of our teams actually include people from multiple different specialties. So we have addiction medicine, we have addiction psychiatry, we have emergency medicine, we have recovery coaches, resource specialists, therapists, psychologists, clinical pharmacists, nurse practitioners, family medicine doctors, OBGYN, kind of the full gamut, depending on which care team. And that, I think, has, again, allowed us to challenge ourselves to really get out of the siloed way that medicine has long been delivered, and to try to begin to holistically meet the needs of our patients. So the timeline, really beginning in 2012, 2013, substance use disorder was identified as a top clinical priority for the hospital. And in 2014, we launched our first clinical services, starting with our inpatient addiction consult team, which was this interdisciplinary, interdepartmental team that could see patients in the hospital and provide expert consultation, engage with them, help manage withdrawal, pain, keep people in the hospital, and importantly, try to use that as a reachable moment to initiate treatment and then connect people directly into ongoing care. We also hired our first recovery coaches, or peers with lived experience, integrated into primary care in those beginning days. In 2015, we focused on integration into primary care, starting with our community health centers, who already had sort of local champions who'd been dabbling in substance use disorder work. And we embedded nurse care managers and recovery coaches, as well as primary care doctor champions, into these settings to really drive change and care at the primary care level. In February of 2016, we opened our Bridge Clinic. Bridge Clinic was named that because we initially thought of it as a bridge from our hospital-based work to the community, recognizing that as we grew our consult team, there really weren't places to connect people to ongoing care, particularly for medications like buprenorphine. And so Bridge was a very simple idea when it began. It was going to be a medication bridge from the hospital to the community. And it rapidly evolved to really try to begin to bridge the many gaps in the treatment system, that it's not just the hospital to home gap that people fall into, but people leaving the emergency room, people who are actually engaged in primary care, but they are dealing with chaotic, severe substance use disorder, and they couldn't keep an appointment or show up on time. So they couldn't access care in the way that the treatment was being delivered. And many other sort of chasms coming out of imprisonment, where people really needed the opportunity for low threshold, low barrier care. In 2017, we expanded our consult team, which started just on the medical services, hospital-wide. In 2018, we opened our perinatal substance use disorder clinic, which tries to provide family and dyadic care. So it has OB, family medicine, pediatrics, social work, recovery coaching, perinatal psychiatry, addiction medicine, all in the same clinical team to try to care for families throughout pregnancy and then through the first 2 years of the child and the family's young life. We also started our addiction medicine fellowship program to train physicians to become addiction medicine specialists. In 2019, we integrated with our long existing addiction psychiatry clinics. We have an adult and a young adult program, and we created co-location and physical space, so new clinical space where all of our clinics could be together, and then continue to focus on expanding in primary care. In 2022, we launched an integrated substance use training program for NP social workers and PhDs, which has been really exciting to train not only addiction medicine doctors, but also the broad care team. And then in 2023, we began getting out of the walls of the clinic to do mobile bridge clinic work in Roxbury here in Boston. We've tried to study this as we've gone along. When we first launched our addiction consult team, we took advantage of the fact that we were on limited floors and limited hours to look at patients with similar addiction severity on floors where the addiction consult team wasn't available, and found that patients seen by the addiction consult team had the greatest reduction in their addiction severity index for both alcohol and drug use at 30 and 90 days. In terms of other impacts, folks who were seen by the addiction consult team had a reduction in 30-day hospital readmission. And so looking at that, I think helped as we continue to try to justify the value of this type of care model, that if we can really engage people in treatment when they're in the hospital, that we can help them stay well and help stay out of the hospital. For opioid use disorder in particular, the readmission rate was greatest on the medical services, where we saw that for patients with opioid use disorder who came in after overdose, the odds of a 30-day readmission were 27% lower when patients were seen by an addiction consult team on the medicine services. We also looked at, in addition to kind of the acute benefit of not getting readmitted or not coming back to the hospital, this idea of our touch points of the hospital system and opportunity for longer term care that continues after discharge. And we looked at individuals who had opioid use disorder or overdose who received an addiction consult and found first that 56% of those individuals were started on medications for opioid use disorder, and that patients were much more likely to be started if they were seen by the consult team than not, but also that the odds of continuing the medication 90 days after discharge was much greater than people who'd been seen by the addiction consult team. So this idea of touch points leading into longer term care. And the numbers tell one story, but I think, beyond the numbers, the patient stories and the kind of human kindness at the core of this is really the part of work that is most important. I think I value the most is seeing my colleagues really treat people with care and with kindness. And this was an email to a nurse practitioner on our consult team from a patient who she'd seen months ago who'd been in the hospital with endocarditis, who said, I'm not sure if you remember me, but you were a light in my darkest times when I was in the hospital. I just wanted to thank you for the times you came in to talk and listen while I was there. It meant more to me than you could ever know. And I love to share this when we're meeting with nurses or, general hospital staff that don't necessarily think of themselves as being a part of treating addiction, because that kindness, that companionship, that accompaniment, any care team member can offer that. It doesn't matter what your specialty is. And it goes a long way, even if in that moment we're not sure where it's going to lead. On the bridge clinic side, we've also looked at the impact on emergency department utilization, showing a reduction in ED visits after people are connected to bridge clinic. And then we looked at integration in the primary care setting, that integrating recovery coaches and office-based addiction treatment nurse care managers and primary care doctors who are addiction champions into practices, that patients receiving care in those practices have a reduction in their emergency department visits and the number of inpatient hospital bed days. And then that across the whole sort of substance use disorder clinical care program, whether it's the addiction consult team, bridge clinic, working with a recovery coach, or seeing an office-based addiction treatment nurse, that if people initiate buprenorphine after a touch point with a substance use disorder initiative, that the duration of treatment is really quite long. So for our OBAT nurses, this is more than 500 days, the average duration of buprenorphine treatment. So really hopefully allowing people to stay connected to care over the long haul. I think some of the work that's been most interesting is qualitative work. So hearing from patients directly about what factors are most important to them. And this was a study we did at Bridge Clinic where people really highlighted, again, how the kindness of staff as being a really important ingredient, that the staff treating them like they're a person, trying to make their life better, encouraging that, that was incredibly important to feel like someone believed in them, that they weren't judged or given a hard time, and that it allowed them to sort of open up and be honest. People highlighted the need to have walk-in services, especially those who are involved in the criminal legal system, that being able to just show up and be accepted and welcomed is really important, and that they felt sort of safe and warm and nurtured. This person said, in fact, I felt nurtured. I think that would be the best word. Some of the facilitators of this work have really been collaboration. I think not only collaboration with our care teams in different departments who are doing this work, like medicine and psychiatry and nursing and social work, but also collaborations with external departments who care for patients with substance use disorder and are open to thinking about how to do better. So we've worked closely with our cardiac surgeons around drug use associated endocarditis and how to think about surgical decision-making and support for people who need valve replacement. Worked with our cancer center around care of people with substance use disorder who who also have cancer, and work closely with our infectious disease colleagues around sort of innovations, for example, pre-exposure prophylaxis for HIV and co-occurring treatment of hepatitis C, et cetera. Our OB colleagues were really foundational in building out our Hope Clinic and continuing to expand our inpatient work. We now have an alcohol-related liver disease clinic that our fellows work in, where they reverse integrate into the hepatology practice. So as the hepatologists are seeing people for alcohol-related liver disease who may or may not have alcohol use disorder, sometimes they're just using alcohol in an unhealthy way, that there's a real opportunity to sort of use that also as a touch point for an addiction medicine encounter. Primary care has been a partner from the very beginning. We also worked with our burns and trauma colleagues who see a high prevalence of people with co-occurring substance use disorder in palliative care. And I think that collaboration has been rich, has allowed us to grow and learn and figure out where the needs are, and has allowed us to really sort of partner with stakeholders in this work. So with that, I want to make sure we leave some time for questions. And I think we have about 9 minutes. So I want to thank you guys so much for having me. Feel free to email me if you have any other questions. I'm still sort of on Z or Twitter, whatever it's called. I used to be much more active on it, but I welcome any connection, and I can stop sharing to see people's faces if that sounds good, or take questions in whatever format works best for the audience.
Thank you so much, Dr. Wakeman, for such a wonderful presentation. I think the optimism that you talk about addiction and the integration into the entire medical system is really powerful. There's a question from on the chat about a keyword that you mentioned in a previous slide, but I have no idea what that means in which slide. I did have a question, so maybe Jamie, I'm not sure if you would want to share additional information about your question. I did want to ask you, I mean, a lot of particularly with the substance use disorder initiative that has been in place since 2013, I think all hospital medical systems across the country are dealing with problems trying to integrate this this issue with opioid use disorder and chronic pain and substance use disorders in general across multiple treatment settings, and having this not be a single department's problem. And so it requires a lot of collaboration, a lot of developing new systems. How do you make a financial argument for that when these are not typically, greatly reimbursed services, and there is a lot of complexity?
Yeah, it's a great question. And I think one we continue to work on. When we were first getting started, we looked at data. So we took a year's worth of admissions to the general medical service and looked at three of our most common diagnoses, so heart failure, pneumonia, and COPD exacerbation, and looked at patients with and without co-occurring substance use disorder. And not surprisingly, found that folks who also had a substance use disorder got readmitted more frequently than expected and had longer than expected lengths of stay. So we're really able to paint the picture of kind of the opposite of value in healthcare, that trying to care for people with substance use disorder without treating their substance use disorder is a really high cost, sort of low value proposition. And so if we're actually able to engage people in care, keep them well, and keep them out of the hospital, that overall saves money and also opens up bed days for, hospital throughput for other admissions. And so that kind of idea of focusing on length of stay and readmission was how we were initially funded. I think what we've learned over time is that actually readmission is the sweet spot where we have the best impact, that it takes fewer days in the hospital to not treat addiction than it does to treat addiction. So actually starting someone on methadone and connecting them to an OTP takes more days than just discharging them as soon as they're medically ready. And so, but I think the payoff is that we can reduce 30-day hospital readmission. And particularly as we move into, a value-based space where more and more we're seeing substance use outcomes in our risk contracts. So things like initiation and engagement and treatment and follow-up after ED visit. These measures finally are starting to make their way as quality measures that have financial price tags attached to them. And so I think that is ultimately the way to show value, that this is good care, and over time people stay healthier and cost less, and payers are seeing that, and payers really want systems to be addressing this. And so I think that's the ultimate place. I think there's an interesting opportunity to think about what does value-based healthcare look like in the addiction space, where some of the most important work that all of us do is not reimbursable on the fee-for-service model, like our recovery coaches, our resource specialists, some of the therapy interventions that happen, are really hard to reimburse in the way, like with the code CPT-based fee-for-service model. And so I think beginning to shift to really about value-based healthcare framework is sort of the long-term best way.
That's great. Thank you. One question that came up, any advice about substance use treatment for adolescents?
Yeah, I think we have an addiction psychiatry program called the ARMS program, Addiction Recovery Management Service, that is for transitional age youth. So it's kind of 14 to 26-year-olds and their family. And one thing is really support for the family. So even if the young person doesn't come into care, that really training families on the craft model can be incredibly powerful. And so I think parent coaching and parent intervention is one really important support. And for young people that have substance use disorder, really thinking about that lower threshold treatment model, because young folks also sometimes can be hard to engage in treatment or have them come back depending on what developmental stage they're in. And so I think that lower barrier model where people can pop into care and drop into care can be really helpful. We also, our recovery coaches have patients sign consent for text messaging support. And if they do, providing text messaging support can be a great way to stay in touch, especially with a young person, and then meeting people in the community. So we have a recovery coach embedded in our transitional age youth program, and she does a lot of meeting people in the community, meeting them for coffee, going to a meeting with them, texting them. And I think that more informal support can be one way to engage folks. My close colleague, who's our clinical director, she's a clinical psychologist was initially a child psychologist by training, and she always describes working with adolescents as that she tries to be the flower that the butterfly will land on, that just be there, be welcoming, and welcome someone in rather than trying to grab them and bring them in. And so as a non-child person, I try to keep that visual in mind.
Thank you. Any other questions? Feel free to unmute yourself, or you can type them in the chat. I'll read. And I have another question for you. And in the meantime, you mentioned at the beginning of the SUD initiative, developing champions in primary care clinics and sort of a number of different settings. Can you speak a little bit more about that?
Yeah, I think that was really important. So I think this combination of sort of leadership saying that it matters. So like the president of our hospital was very proud of this work and would talk about it and, share about it and send messages that it was important. And I think that carries a lot of weight. But if people feel like it's just this sort of leadership on high thing that's not actually supported on the ground lines, it can feel like kind of an unfunded mandate. And so I think linking kind of the leadership voice with the on the ground, both having a peer champion and having supports right there in the practice was really important. So for the primary care sites that we worked with, we basically centrally funded a recovery coach and a nurse care manager. And the ask of the site was that they would identify a physician champion in the practice. They would agree to come together for what we called risk rounds, which was an opportunity to talk about complex cases. And in the beginning, both myself and our clinical psychologist would go to every one of those sessions and we would talk about cases with them. And so part of this was building sort of a culture of people not worrying alone, that when they felt like they were anxious about caring for substance use disorder, they could come talk about a case, they could get the recovery coach involved, the nurse care manager involved, and then it wasn't kind of all on their shoulders. And so I think that combination was really helpful. And then those peer champions, the physician champions, became sort of the colleague that people could turn to in the practice of grabbing someone in the hall and, asking a question about buprenorphine or naltrexone or a case. And that actually goes, I think, much further than someone that you don't know that you're supposed to turn to. Like a lot of these mentorship programs nationally are, it's like a mentor you've never met before. And at least internally, what we found was that we actually tried for a while assigning PCPs to mentors. And if it was a mentor they knew, they were actually very likely to reach out for questions about substance use disorder. But if it was someone at a different practice or a different institution that was just a name without a face, they rarely used it. So I think as much as we could have kind of peers on the ground, that seemed to diffuse change much more effectively.
I love this idea of risk round and not worrying alone. I think not using alone is something that we use a lot in the substance use field. And within our outpatient addiction psychiatry clinic, we provide a lot of consultations to PCPs and then the possibility of referral back if there's a complication. But this idea of, if you start treating addiction in your clinic in whatever space you are, you can bring up any really complicated patients to a multidisciplinary group to help you solve it together. That's fascinating.
Yeah. Thank you.
I think we have a minute left. I'm not sure. I don't see any additional questions in the chat.
Thank you guys so much for having me. I really appreciate it. It's been really great to join.
Thank you very much, Dr. Wakeman. We really appreciate your presentation and enjoyed it.
My pleasure. Yeah, I hope you guys all have a wonderful day. Enjoy the sunshine, even if it's a bit cold.
Thank you.
And it was great.
Thank you so much.
All right, take care.